would like to introduce Dr. Pratibha ma'am, Associate Professor from the Department of Psychiatry, AIIMS Jodhpur. Ma'am's area of interest include child and adolescent psychiatry, women mental health, affective and somatoform disorders. Ma'am has more than 30 research articles in national and international reputed journals to her credit. With this brief intro, I'd like to welcome Dr. Pratibha ma'am. Please share your expertise, ma'am.
Yeah, the other one has to stop sharing the screen.
Yes, ma'am. Has it stopped sharing, ma'am?
It has been stopped shared.
Okay.
So the screen is visible to all and I am audible?
Yes, ma'am. Everything is perfect. Please go ahead.
Good evening. So without wasting any further time, I would like to just point out the screening and counseling in intimate partner violence. So from where it is to change? I'm not able.
You can just click the cursor.
Okay. So while we encounter any person or any female or any other gender with intimate partner violence, we have to actually begin with asking about IPV. And it's not about that we can say that we have witnessed any person or anyone in a very open manner are telling about intimate partner violence. If we suspect these things with some injuries or with some emotional state, we have to start with asking about IPV, in which we have to begin with opening the statement that whether you feel safe at home or any violence has occurred to you, anything which is bothering you at home, we have to screen for past IPV. It can occur in the past also. So we have to start asking about that in the past also. It is not that currently or in the past you felt safe at home or anything which bothered you or any your partner or anyone else in the family has been hitting you or blaming you or any passing any comments. So whatever, we have to start asking the questions and screening for the current IPV. So if the patient answers yes to any of the current intimate partner violence screening questions, continue with the other set of questions. So this is a screening tool which has been given by WHO, HIT screening questionnaire, in which we have to ask about physically hurting you, physically hurts you, insult or talk down to you, threaten you or physical harm, with the physical harm, scream or curse at you. So these 4 questions we have to rate: never, rarely, sometimes, fairly, often or frequently. And this is usually known as HIT screening tool. And each point is rated on 1 to 5. A score of greater than 10 is considered for intimate partner violence, and counseling is recommended if the score is greater than 5 has come on this score. So the thing is that we have to break the phenomena of silence and we have to start asking about the intimate partner violence. Then express, if the answer is yes or some bit of violence is there, we have to start with expressing empathy and concern. We have to name the patient and say, I am so sorry to hear that this has happened to you, and it's really important for you to understand that everyone has the right to be safe and treated respectfully, including you. Like these phrases, the violence that you have described should not have happened and is not your fault, and even if you think you may have triggered it in some way, it's not your fault. You do not have to blame on yourself. Then assess the readiness to make a change. Now you have confirmed that the patient or the person has been suffering from intimate partner violence. We have to start asking about the past efforts. If in the past there were incidences of intimate partner violence, then there were any efforts to bring change, to change something or change the situation, and assess readiness to make change at the presently in the given situation. So like these questions we can say, okay, so just you get a sense of where you are on a scale of 1 to 10, where I mean not important and 10 means very important. How important would you say it is? It is to try to address this problem right now. So we have to actually assess the readiness to make a change. Then if the person is ready for change or not at all change, then we have to give advice on the next steps, provide affirmation and state your concern, like thank you for your honesty and for sharing this with me. I know this is really difficult to talk about. To tell you the truth, I am concerned about your safety at home. You have to actually say the partner's name as well as the patient's name if you want to actually build a rapport with them. Explore the desired changes. What is the number one concern? What is your number one concern at this time? How would you like things to be different at home? Make a recommendation that I have a couple of ideas that might help, and let's explore some options for dealing with it. So whatever the help and support system available with the female or the person coming to you with intimate partner violence, you have to explore and accordingly give the advice on the next steps. If the patient says yes, that I want to, I am ready for change, then yes, patient is ready to make a change today. Move to assist and provide resources and arrange for follow-up. In these cases, we are actually lacking because we do not know that we do not have ready resources at our hospital settings or other settings or PHC settings. And that is why the assistance and providing resources and arranging for follow-up becomes very difficult. So I think this is the lacking thing we have, and we should work on this. As a public health, I think this has been organized by the community medicine people. So I think this is the most important part, that we should be ready if the patient comes up with it. If the patient says no, the patient is not ready to make a change today, manage the resistance and avoid confrontation, and restate your concern and keep the door open while the patient or person comes to you for a change. Then yes, assist and provide resources, connect the patient's goal with specific referrals. Like the other people, the other medicine people, they have said that gynecological referral, ophthalmological medicine referral, surgical referral or whatever specific referrals, and what are the goals of the patients. Make a plan for safety. This is very, very important. As a psychiatrist or a primary person in contact with that person with intimate partner violence, that provide patient with a copy of personal safety plan which is available, and this plan can be made at that point of time personalized according to the information given by the person himself or herself. Then arrange for follow-up. Arrange for follow-up visit and establish clear contact information. Discuss a safe way to identify yourself on phone, identify a code word and phrase for calling the police or ending the conversation. So these are the things we have to actually tell to the, but the readiness to change is very, very important. So that we have to keep on working, and we have to be ready with the resources. So I guess this finishes the counseling and the psychiatric aspect, the counseling aspect and screening aspect of the intimate partner violence. And then I want to continue with the implications of intimate partner violence on mental health. So this is very important, because it has been found that there is a bi-directional relation between intimate partner violence and mental health problems. Intimate partner violence, because it has both, it works as a both predictor of future mental health problems, and it can also be a possible consequence of such mental health problems. then we can actually understand it by this, that it can present as a risk factor for development for mental health problems like anxiety, depression, substance use disorder, post-traumatic stress disorder, personality disorders, psychosis, self-harm, and suicidality. They are more common among people who have experienced IPV than those who have not. So many systematic reviews and meta-analysis, they have come to the conclusion of this. Although many studies, they are cross-sectional in nature, and nothing has been, very few studies are longitudinal or more. These people, intimate partner violence makes the risk of having more persistent mental health problems, and chronic exposure to intimate partner violence is associated with more severe mental health problems. It also acts as an independent risk factor for suicide attempt, and it is also seen and and has a big level of evidence that history of child maltreatment or child who has exposure to IPV, there is increased risk of experiencing IPV in their adulthood also. So over a span of life, all these problems are there. Then we can understand on this thing that mental health problems as a risk factor for experiencing IPV. People who have mental health problems, they are at increased risk for IPV. It is not that only IPV increases the risk of this, but the people having mental health problems, they are also at increased risk for IPV. This increased risk could be result of abusive partners inflicting violence when individuals with mental health problems are assumed to be less able to protect themselves. For example, during certain psychotic states involving disinhibition or preoccupations with the one on thought, they are more vulnerable to IPV. Then mental health problems is a risk factor for perpetrating IPV. So they become a perpetrator. And this can be well explained that risk of IPV perpetration is higher in individuals diagnosed with depression, generalized anxiety disorder, and panic disorder than those without such diagnosis. And risk of IPV perpetration was more strongly associated with alcohol, drug use problem, and comorbid substance use. So that has been previously pointed out by the police personnel and police resource person, the IPS officer, sir, that this alcohol and drug use, they are the main culprit, and it has to be dealt with very strongly by the public health sector. The connection between substance use and IPV perpetration is complex, and the environmental, situational, social, economic, and cultural context of this link should be carefully considered. So we do not have to forget these links. Psychological traits such as anger, hostility, jealousy, they have strong associations with IPV and might be more prevalent in some individuals with mental health problem. So lastly, I would like to say about, I would like to read a survivor's account in which she describes that how childhood experiences affected the adulthood relationships. So this is: personally, to survive my childhood, I learned to doubt my own experiences to maintain the adults in the light of caring individuals. It was safer to question my behaviors than theirs. I couldn't control them, but I could control myself. So I thought I must be wrong in thinking or doing such and such since they said so. I used the same strategy when in relationship with my abusive partner. The pattern of self-doubt carried on in my adulthood and still makes me more vulnerable to intimate partner violence. In my life, I have had more experiences of disempowerment than empowerment. So whenever the former shows up, it has more weightage. It is a lifetime's work to shift the balance. For the cycle of abuse to stop, one has to have more positive, healthy relational experiences than abusive ones to create the new norm. So with this account of the survivor of the intimate partner violence, we can predict that it is a lifelong process. It actually starts with the birth of the child, the environment the child lives in, and so we need a great change in this. Then I would like key factors for future research: improved understanding of the factors across multiple levels, individual, family, relationships, social, cultural, economic, and political structures might protect IPV survivors from adverse mental health consequences. And it is imperative that future studies are designed and conducted in collaboration with survivors or wholly survivor-led to ensure the perspectives of those with lived experiences of IPV. They should be the central to the research. So with this, I thank you all